All right, let's jump right into this explainer. We're doing a rapid-fire review of high-yield clinical presentations. The goal here? Building that visual spatial memory you're absolutely going to need for test day. We're skipping the intro fluff and getting straight into the clinical triage algorithms that literally separate a passing score from an exceptional one. So, to build your test day decision logic, we're going to sprint through a few different wards of the hospital. All of this comes straight from highly curated community-generated notes. It's the exact kind of high-yield stuff designed to give you a serious edge when you're staring down a super tricky vignette. Here's our game plan. We're covering acid base and metabolic derangements, neonatal wards looking at jaundice and scalps, the blood bank for transfusion reactions, vasculitis and pediatric rheumatology, and finally, neuromuscular weakness syndromes. 5 quick stops, packed with pivot points examiners just love to test. Section 1. Acid base and metabolic derangements. Our first stop is the ER. We're dealing with some complex metabolic abnormalities here, and honestly, having a solid visual framework for this is going to save you precious minutes on the clock. Just look at how elegantly this branches out acidemia and alkalemia based on PCO2 and bicarb levels. You start right at the top, right? Check that arterial pH. Under 7.35? Boom, you've got acidemia. Next, look at your bicarb. If it's low, say under 20, well, now you're dealing with metabolic acidosis. And that brings us to the absolutely critical branch point, checking the anion gap. This is where you need to anchor 2 huge mnemonics. You've got gold mark for high anion gap causes, things like glycols and lactic acidosis, and then you have hard ass for normal gap causes like diarrhea and renal tubular acidosis. So, if you calculate an anion gap and it's strictly over 12, your brain needs to immediately flash to gold mark. Think toxic ingestions or renal failure. But if it's a normal gap just sitting right there between 8 and 12, think hard ass. That's usually severe diarrhea or maybe massive saline infusions. Keeping these 2 buckets totally distinct in your mind, absolutely essential. Okay, Section 2, neonatal wards covering jaundice and scalps. Let's move over to the NICU and see how these neonatal pathologies compare. We're going to look at a couple of the most commonly tested newborn presentations out there. This breaks down the super strict timing differences in neonatal indirect hyperbilirubinemia. Basically, whenever you get a vignette about a jaundiced newborn, the absolute first thing you need to look for is the infant's age in days. It's the ultimate clue. Let's test your decision logic. If the baby is under a week old and showing signs of dehydration, that's lactation failure. The infant just isn't getting enough breast milk, which means decreased bilirubin elimination. Simple as that. But wait, if the jaundice peaks around 2 weeks, and the baby's perfectly well hydrated, feeding totally fine, well then it's breast milk jaundice. That one's actually driven by beta-glucuronidase in the breast milk itself, which ends up increasing the enterohepatic circulation. Crazy, right? Moving on to the nursery physical exam, visually anchoring these neonatal scalp swellings is vital. Check out how caput succedaneum is essentially just edema above the periosteum. And what does that mean? It means it easily crosses the sagittal suture. But a cephalohematoma? That is a subperiosteal bleed. It's tightly trapped under the periosteum, so it strictly respects those suture lines. It does not cross. So, why does this distinction actually matter for prognosis? Well, caput succedaneum is soft, it's boggy, and it usually just self-resolves. No big deal. A cephalohematoma is firmer, doesn't cross sutures, and carries a major risk for hyperbilirubinemia, mainly because that trapped volume of red blood cells eventually breaks down. But here is the critical test day emergency, a scenario you absolutely cannot miss. If the swelling crosses suture lines, feels fluctuant, keeps expanding over days, and you're seeing tachycardia and pallor, you must immediately suspect a subgaleal hemorrhage. We're talking life-threatening blood loss here. All right, Section 3, the blood bank and transfusion reactions. Let's head down there and examine these immediate versus delayed immune responses. What actually happens when a blood transfusion goes wrong? The board exams love, I mean literally love, to test the specific timeline and mechanisms of these transfusion reactions. The onset time, that's your absolute best clue in these vignettes. Pay close attention to the distinction in onset here. An anaphylactic reaction happens incredibly fast, like seconds to minutes. This occurs because of preformed anti-IgA antibodies in an IgA-deficient patient who just got donor blood containing IgA. You're going to see respiratory distress, wheezing, hypotension. You need to stop the transfusion immediately and give epinephrine. Now compare that to an urticarial reaction. That takes hours to develop and mostly just presents with hives and itching, usually due to recipient IgE antibodies reacting against some soluble allergen in the plasma. In sharp contrast, a delayed hemolytic reaction occurs anywhere from 24 hours to a whole month later. It's super sneaky. This one's driven by an anamnestic antibody response to a minor red blood cell antigen the patient was exposed to in the past, maybe from a previous transfusion or a pregnancy. The patient will present with fatigue, jaundice, maybe a low-grade fever, and crucially, a brand new positive direct Coombs test. Okay, moving on to Section 4, Vasculitis and Pediatric Rheumatology. Here we're facing several look-alike diseases that you absolutely have to be able to untangle quickly. Let's do a rapid-fire comparison. First, TTP, or thrombotic thrombocytopenic purpura. This is caused by an acquired autoantibody that decreases ADAM-TS13. This basically leads to uncleaved von Willebrand factor multimers running around trapping platelets. But crucially, you will see a totally normal PT and PTT. On the flip side, we have HUS, or hemolytic uremic syndrome. That's triggered by vascular damage from a Shiga toxin, and it almost always follows a bout of preceding bloody diarrhea, usually from E. coli 0157 H7. Next up, IgA vasculitis, which you might know as Hennig-Schindlin purpura, or HSP. You really need to know what to look for here. The rash typically starts out as just petechiae, but then it coalesces and darkens over a few days into palpable purpura. And here is the classic tetrad you've got to commit to memory. Palpable purpura on the lower extremities, arthritis, abdominal pain, which by the way can actually trigger intussusception, and renal disease. Now, remember, that renal disease might not be obvious when they first walk into the clinic. Actually, scratch that, it might not show up for months. That makes serial urine analyses an absolutely critical step in managing these patients. Finally, Section 5, Neuromuscular Weakness Syndromes. For our last ward, we're doing a neuroconsult to pinpoint the source of a patient's motor weakness. The map we're looking at is a beautiful visuospatial breakdown of weakness by anatomical location, all the way from upper motor neurons down to the muscle fibers. The second you get a weakness vignette on the test, this should pop into your mind. Are there upper motor neuron signs? Or maybe we're dealing with peripheral nerves, like in Guillain-Barré. Well, today, we're going to zoom in right on that neuromuscular junction. The absolute pivot point for your exam when telling these two paraneoplastic syndromes apart comes down to this. Myasthenia gravis targets postsynaptic acetylcholine receptors, right? So it features fluctuating weakness that gets worse with use, typically hitting the ocular and bulbar muscles. Lambert-Eaton syndrome, on the other hand, targets the presynaptic voltage-gated calcium channels. It presents with proximal muscle weakness and, here's the real key differentiator, absent or diminished deep tendon reflexes. Don't mix those up. Wow. Okay, we've covered a ton of ground today. This explainer really highlights the incredible power of the Inner Circle community and just how vital collaborative learning is for conquering these medical boards. It's notes exactly like these, built by test takers for test takers, that really cut through the noise and clarify what's actually important. So I'm going to leave you with a question. When you're sitting there on test day, staring down two look-alike pathologies, are you going to rely on rote, memorized lists, or are you going to trust the visual spatial decision logic you just built today? Keep refining those visual pathways in your mind. Picture the flowcharts, anchor the locations. Do that, and you're going to be perfectly positioned to absolutely crush your exam. Thanks for joining me for this explainer, and happy studying.